So it's been that kind of moment. So again, welcome everyone. Thank you for joining us at this our 51st Mrftt HIV STI Echo. I'm Dr. Boyce, as you all know, and the hub with me is Dr. Musa, Dr. Parbu, and Ms. White just went to the back. She's before you can't see her, but she's here. She's lending her supportive presence. So we're going to get started, and so you would have seen the recent WHO guidelines, the new consolidated guidelines come out just a couple of days ago. It's a wonderful document. It's over 500 pages, almost 600 as a matter of fact. And it's actually composed of multiple guidelines that have been kind of put on one by one. So there's a guideline on cryptococcus, another one histoplasma, another one tuberculosis. Then in March they put out a guidelines on HIV management and monitoring and lab diagnosis, and then another one on service delivery. So when I had actually started to work on this, I had taken from those two documents, and lo and behold, the big boy turns up. So we sort of put everything together, and rather than try to give a comprehensive conversation about everything, that would probably take over several hours actually. We're just going to talk about the changes that happened between the last consolidated guidelines and these. So I'm going to get the presentation started. Now remember, as usual, if I speak too quickly or having difficulty hearing, let me know. I sometimes chew my words a little bit. So let's get the party started. All right. Okay, so the presentation is going. All right. I hope everyone can see the screen. So we're going to talk about updates to WHO guidelines for management of HIV. So as usual, I just want to acknowledge all the support we've had from ITEC and from University of New Mexico and their Project ECHO program over the years. So I have no actual potential conflicts of interest. That may be good or bad, I don't know. So the learning objectives for today's session would be to outline the recent updates to WHO guidelines for the management of HIV, to discuss the evidence based underlying these recommendations, and finally to discuss how these recent guidelines can be adapted to a local and regional context. So as I was saying before after we started the presentation, these are the two sort of documents I started working with respect to preparing the change in guidelines. The first is the updated recommendations on prevention, infant diagnosis, ART initiation, and monitoring. And the second, to the right, is the updates to service delivery models and treatment and care of persons living with HIV. Because remember, differentiated care delivery is very much the watchword. And while I was working on, as I said, on this presentation, the 600-page document came in, which I started to look at, but that's my said just got the highlights, the press of the press sort of stuff to present to you here today. So with respect to recommendations for antiretroviral treatment, nothing much has changed, but I thought I would still have a conversation about it for the purposes of emphasis. So the 2016 guidelines are more or less still in force. Antiretroviral therapy should be initiated on any person, regardless of clinical stage or CD4 count, in adults, pregnant and breastfeeding women, adolescents, and the evidence based on adolescents is slightly less robust, but I think on general clinical grounds it's still highly recommended, and definitely in children and in infants, because it's in infants especially who are perinatally infected, mortality rates can be very high early on in life in the absence of antiretroviral therapy. So what do we start? So remember there has been this general shift towards integrase inhibitors globally, dolutegravir being the agent of choice in low and middle income countries. Unfortunately, there was an issue in Trinidad such that we have not had good access to dolutegravir, which is much to our chagrin, as right now is showing we are in desperate need of another agent with which to give our patients who are having difficulty with efavirenz and who are not able to tolerate protease inhibitors. Dolutegravir would have been a perfect molecule. In terms of what the alternatives would be, so efavirenz 400 milligrams has been available, but that would be with the caveat that the rates of non-nucleoside resistance in the general population must be less than 10%. Otherwise, you're setting up people for treatment failure later on. And if neither of those two are possible for whatever reasons, various combinations of raltegravir as a third agent, a boosted protease inhibitor, either atazanavir or piniviretonavir, or full dose efavirenz, and with various different backgrounds, like AZT or abacavir. With children, dolutegravir is the preferred agent. If that's not possible, then a boosted protease inhibitor. Tenofovir is generally not used, as it's not for disoproxil in children due to the concerns about bone and renal toxicity until at least the skeleton is matured. And again, alternative agents, either piniviretonavir, TAF in certain populations, and if neither of those things are available, then a non-nucleoside like efavirenz or nevirapine, or even raltegravir. And in neonates, raltegravir is a preferred agent. There are dosing formulations available for children. And failing that, again, our good old friend nevirapine or piniviretonavir. So in terms of what we do with dolutegravir in pregnant women, some of you will remember, or many of you will remember, that there was a significant controversy early on in the world of dolutegravir in Botswana, where one of the cohorts showed there was increased risk of neural tube defects, and there was a sort of an embargo on dolutegravir, and there was advice that it shouldn't be started at women of childbearing age until after the second trimester, and all those sorts of concerns, which over time, gradually the rate of neural tube defects eventually came down significantly. But the WHO essentially put out a statement saying that we should have a woman-focused approach in terms of how we address antiretroviral therapy and treatment, and try to balance some of the medical paternalism that can sometimes seep into a conversation with female patients in particular. And I thought the guidelines summarized what the concern would be with not using dolutegravir, given that it is, especially in populations where there is a certain amount of background resistance to efavirenz, a much preferable molecule to use. So essentially, based on 2019 data, where if you assume a background resistance of 9% efavirenz, avoiding the use of dolutegravir and using efavirenz instead, because we're worried about neural tube defects, would eventually have the effect of 21 additional deaths among women because of rates of treatment failure and drug resistance. There would be 26 sexual transmissions because of these comparatively lower rates of viral suppression of efavirenz compared to dolutegravir, and there will be 40 more of the child transmission. The difference in child deaths would not be modeled, but essentially 125 disability associated life years accumulated. So I think that essentially states very clearly and in a very sort of graphic way why we should have a respectful conversation with our patients about if dolutegravir ever becomes available in Trinidad, about the potential risk and about the potential benefits, and allow them to come to the one conclusions. So in terms of what we do in second line therapy, so again, it depends what the first line was. So the first line, as it is in Trinidad at this time, non-nucleoside based primarily efavirenz with a backbone of limivudine, tenofovir, or most commonly emrysiptine tenofovir. Then the second line switch empirically in the absence of resistance testing. And we're hoping to have a conversation about that actually with Dr. Behrens about how we go about and what the evidence base is that underpins a lot of this empiric switching. So if the backbone is to the FTC TDF along with a non-nucleoside, then you switch to dolutegravir. If you're starting from dolutegravir and you're filling in dolutegravir, you recycle the nucleosides and switch to boosted protease inhibitor. And if, for whatever reason, those options are not available, then you think about using something like piniviretonavir or an alternative protease inhibitor. And again, for children and infants, if you're starting with dolutegravir, you go to a PI, which recycle nucleosides. If you're starting with a PI, you recycle nucleosides and you go to an integrase, either dolutegravir or in some cases raltegravir. And if you're starting with a non-nucleoside, you go to an integrase or boosted protease inhibitor. So with respect to what we do for third line, generally the WHO, I think in its wisdom, has not been dogmatic with respect to what regimens it would recommend, primarily because when you get to a point where considering third line therapy, usually you would have significant accumulation of drug resistance mutations and significant compromise of available active drug options. So the general broad guidelines would be, again, if possible, have those choices guided by resistance testing. If not, based on the person's previous treatment history and previous history of regimen failure, construct a regimen is likely to be suppressive. And in the case, and we've had similar cases, especially among some of our adolescent population, where there are few active options, then you would use the most active option you have available. Because there has been research that demonstrates it is better to have someone on a partially suppressive regimen than to stop the regimen and have viral replication unchecked that actually is associated with higher rates of mortality. So that hasn't changed in terms of treatment guidance. What has changed? So this is the first item we're going to have a conversation about that did change between 2016 guidelines and the 2021 guidelines. So again, most of the clinicians remember the conversation that we keep having about when you start treatment in somebody who's HIV TB co-infected. First question is, what's the CD4 count? It was less than 50, then you start TB treatment within 2 weeks of antiretroviral treatment within 2 weeks of the TB medication. With more than 50, you wait 8 weeks and start the antiretroviral therapy after the anti-TB therapy. Now, that has changed. So the guideline is now that antiretroviral therapy should be started as soon as possible within 2 weeks of initiation of anti-TB therapy, regardless of CD4 count, whether it's 1 or 100 or 1,000. And this is, the evidence is strongest in adults and adolescents. There is less of evidence based on children and infants, and there's an important caveat to this, that this only holds if there is no suspicion of TB meningitis. So, because if you do start treatment prematurely with TB meningitis, there is a possibility of severe adverse outcomes and even death. So, that being said, the question would be, what is the evidence base that underpins this change? So, the systematic analysis that informed its choice in 2016 was based on studies that did not directly compare persons starting antiretroviral therapy within 2 weeks of anti-TB therapy directly with somebody who started within 2 to 8 weeks. And in for this systematic analysis that informed 2021 guidelines, they repeated the 2015 review using new CD4 data that was not available when the initial guidelines were promulgated. So what it showed, and I'll just go to that slide before I come back, is that there was similar mortality between patients starting antiretroviral therapy within 2 weeks versus 2 to 8. There was lower mortality still among persons with CD4 less than 40, less than 50, sorry, commencing treatment within 2 weeks versus later. And similar mortality in persons with CD4 counts greater than 50, starting antiretroviral therapy within 2 weeks. So essentially, what it was showing is that you got the benefit of earlier initiation of therapy when a CD4 count was less than 250. And if a CD4 count was more than 250, there was no harm, other than a possible increased risk of immunoconstitutional inflammatory syndrome, which can sometimes happen. That was one of the major reasons that drove the concern about starting antiretroviral therapy to close to TB therapy. But that's were extremely uncommon. So that would be something you have to consider looking out for in someone who is starting anti-TB treatment earlier and manage that. But the likelihood of fatal outcome is extremely small. So just to go back to the previous slide, some of the limitations of the systemic analysis were that all the available studies were done prior to 2014 using older drugs. So some of the newer drugs that were being used in antiretroviral therapy now, you couldn't make a conclusive statement that someone who's on enough for dolutegravir with a CD4 count of X who started anti-TB medication will have Y outcome based on data where somebody might have been on, I don't know, efavirenz or AZT or D4T and some other drug that we just don't use anymore. And the other limitation is that there is no available data for women of childbearing, so for children less than 13 years old, pregnant or breastfeeding women, and in patients receiving second-line therapy. So in terms of HIV/TB co-infection as well, the previous guideline with respect to, if let's say you're seeing a patient and they have a cough and a fever and some night sweats, and you're concerned that this is the first time you're seeing them, they've recently enrolled in care, and you want to start them on treatment, but they have some of those symptoms that WHO 4 symptom screen that makes you think that this might be tuberculosis. That the previous guideline was, don't start antiretroviral therapy right away. Investigate them for possible TB. And when that investigation is completed, and you know whether they have TB or not, then you make a clinical decision based on that. So the 2021 guidelines have actually flipped that around and said, among persons living with HIV with signs and symptoms of tuberculosis, except again, CNS symptoms suggestive of meningitis, initiate treatment while you are investigating them for tuberculosis. But, and that last phrase is important, with close follow-up within 7 days to initiate treatment, TB treatment if TB is confirmed. Now, the reason why this was promulgated is that the symptom screen, WHO 4 symptom screen, is not a sensitive indicator for tuberculosis. It means that it would miss, even in patients with symptoms, most of the cases when they did the check-only studies, most of them turn out to be to not have TB. And the danger of withholding antiretroviral therapy is somebody who's clinically unwell while you make sure they don't have TB, and it still doesn't end up being TB. Some patients might run the risk of actually getting more ill or dying as a result of that need. So a couple of studies have actually demonstrated that saving the ART was feasible while investigations for TB were ongoing, with the caveat that with at least one of those studies, they had access to the TB LAMP, like what Arabinamide screen. So at least you had another level of screen that you could implement while you're waiting, while making your clinical decision. But the limitation is that the evidence is scanty with respect to answering this question. And one of my concerns, because having treated personally with HIV and TB at Cora, I have lived experience of patients in Cora sometimes waiting weeks to get let's say a gene expert result back. I think one of my patients was waiting over a month. So I would only be comfortable with this recommendation if I don't get results back in a week. Because in a week, you can be conclusive about whether it is a TB or not. And if you're sure getting a result back and you have concerns about that this person is clinically unwell, TB is a bit shaky, getting my results back in 7 days time, we can have it 7 days. But if you're not sure how long it's going to take, then there might be a serious possibility that you're pushing somebody into IRIS without any set end date as to when you're going to actually turn that inflammatory tap off, for want of a better term. So next conversation will be about laboratory monitoring, and that's going to be very mindful of the time. So we're going to compare 2016 viral testing strategy to 2021 viral testing strategy. And that little star there by the viral of 1,000 copies essentially is to have a conversation about why the 1,000 copies threshold, because it used to be 5,000 in the past, it washed it down to 1,000. And there's an ongoing conversation as to whether or not that is too high. Should we bring it down and start making clinical decisions about switching antiretroviral therapy at lower viral loads? And there is some evidence that suggests that at viral loads, let's say between 500 and 1,000, if it's persistent for several months, there is the development of drug resistance even at those lower viral loads. But that is counterbalanced by evidence that with respect to transmissions from the positive part of the negative part of the steroid relationship. We know the partner studies and so forth at virals less than 200, there was no transmission. There was a study as far back as the year 2000 that demonstrated that with virals less than 1,500, there was no transmission. And even so, and there is evidence that at virals less than 1,000, there is very little, if any, actual transmission going on at those low virals. The transmission rates from mother to child are generally in the range of 0.3 to 0.2%, so it's still extremely low. So from a public health aspect, the question would be, is there a public health benefit to readjusting the viral loads at a lower level? The argument to that would be, the less resistance you have, the easier it is to switch, and the more likely your second line therapy is to be successful. So this. Right. So next conversation regarding how frequently monitor viral loads. So the WHO actually does not recommend a baseline viral load. The first viral load they recommend is at 6 months post initiation of antiretroviral therapy. The debate was, is that too late? Should we do it at 3 months instead, so that you catch early treatment failures and make make a decision regarding switching? The problem is that if you compare dolutegravir to efavirenz, at 3 months you would have a higher rate of suppression on a dolutegravir-containing regimen, for example, than on a efavirenz-containing regimen. And it might make you think, well, the person who's on efavirenz-containing regimen is failing. However, by 6 months, the rates of viral suppression are essentially identical, because efavirenz just suppresses viral less rapidly than dolutegravir. So the danger of making treatment decisions based on, let's say, a 3-month viral load is that you might end up switching patients to a second-line regimen who don't need to switch. It may be a manifestation just of the fact that efavirenz doesn't suppress virus just as quickly, or if you start off with a high viral over 100,000, they take longer to suppress. Also in children, they take longer to suppress. So the decision was, leave it as is. Viral load at 6 months, 12 months, and then every 12 months thereafter. At the Mrftt, we still do baseline virals, and we still do virals at every 6-month interval. One of the other issues that, and this is new for this regimen, is that on persons on non-nucleoside-containing regimen like efavirenz, like Mrftt, the proportion of persons who have been on antiretroviral therapy for greater than 6 months to a year, with a viral load over 1,000, let's say a year under therapy, we do a viral load of viral loads over 1,000. The usual algorithm is repeat the viral load 3 months and check back and do adherence counseling and that sort of thing. But several studies have demonstrated the risk of treatment drug resistance mutations having already arisen to the non-nucleoside class is somewhere between, in some studies, 47% to as high as 94%. So there is some suggestion, and these guidelines reflect that if you have somebody on non-nucleoside-containing regimen, and if at any point in their treatment career, especially if you believe this person is adherent, they have a viral over 1,000, switch them immediately. Don't do the 3-month follow-up, don't do the enhanced adherence counseling, just switch them. And again, there is the debate about, well, if you were to go through, and again, a study has shown that if you were to go through the whole adherence counseling, about 40-something% of those might wind up resuppressing. So are you switching people prematurely? So again, there is still some tension, I think, regarding how to implement that particular recommendation. But it is, I think, useful to at least have in the back of your mind to have a very low threshold for abandoning a non-nucleoside regimen if somebody is very ill. So with respect to these frequency with which you do follow-up testing after initial viral over 1,000, the 2016 guidelines said every 3 to 6 months, but when analysis was done as to how well that was being implemented, because that was a bit, I would say, I don't want to say airy-fairy, but not quite as clear as it could be, since we're having viral loads done at extended periods of time, essentially meaning that they were varying for longer periods of time. So that the WHO essentially said you have to have a follow-up viral load after a previous viral over 1,000, which is over here, at 3 months. Right. And if the person resuppresses, so less than 1,000, you continue with same regimen and continue adherence counseling. If they don't resuppress, you switch to appropriate regimen. Now, this insistence on making a treatment decision at 3 months leads us to our next point with respect to how we monitor the variables. Because remembering now that a lot of these studies upon which these recommendations are based are done in parts of the world where lab infrastructure is perhaps not as reliable as it is in certain other parts of the world, so that you can have a long period of time between time you take a sample and time you get a result. And I'll get to that a little bit later. Now, if you have someone whose regimen is failing, and you need to make a treatment result sooner or better than later, for both individual and public health reasons. Because if the viral is suppressed for extended periods of time, the virus is wearing on the immune system, they run the risk of becoming ill with opportunistic infections, they run the risk of transmitting to their partner or to their unborn child. So that led to the recommendation that viral load monitoring can be done using point-of-care machines. I think the two that are WHO pre-approved are the gene expert machine actually that can do PCR testing. I think the Abbott M Prima, which is another point-of-care machine. Now, what are the benefits of point-of-care testing? Well, it results in faster processing. Essentially, you get a result within an hour or two, you can make a decision with the patient in front of you, as opposed to them coming back in a week, a month, 2 months, 3 months, risk of loss of follow-up, risk of morbidity and mortality. And it also results in higher rates of retention and care versus your standard lab-based viral load platform. So there is a limitation, however, because each of those point-of-care machines can do about 6 to 8 viral loads a day. And for example, at Mrftt, where we're taking maybe 80 viral loads, 60 viral loads a day, that's not going to be manageable as in terms of your general response. So the WHO recommended that you use point-of-care viral load testing for most of the risk groups. For example, pregnant and breastfeeding women, where you need to know today if this woman who is in her 3rd trimester is suppressed or not, so you can make an appropriate decision with respect to her treatment. Infants, children, and adolescents, because they have a risk of viral failure. People who require repeat viral load again after first elevated viral load, because if someone is having difficulty with adherence and their treatment is failing, the sooner you can make a decision with respect to changing the therapy, the better. And if you do it on the same day, better yet. And the persons who have advanced HIV disease or someone is re-entering care. But as I said before, the evidence is derived from studies primarily performed in sub-Saharan Africa. And local infrastructure and active connectivity, for example, may determine whether or not this strategy is feasible. For example, our viral turnaround time is about 2 weeks. Do we need to invest in a more costly platform for a 2-week change in viral load? And I think the only way we will know that is if we analyze the data and see are we having adverse outcomes as a result of delay in persons receiving the results. And similarly, the recommendation is that early infant and child diagnostics be done on a point-of-care basis. Again, with studies in sub-Saharan Africa where about 15% of infants are dying waiting to start antiretroviral therapy because it takes about 40-something days just to get a test result. And it might even take as long as 214 days before the infant actually starts treatment. Reflect on the fact that mortality is highest in the first 2 to 3 months, right, of in a perinatally infected child, an infant. So that you need a quick turnaround time with respect to receiving those results. So again, it's having a point-of-care platform results in a turnaround time essentially of 0 days, because it's done while the patient is still there, as opposed to 35 days standard of care. 90 versus 54% of infants started ART within the first 60 days of sample collection, and there was a 40% increase in retention care at 90 days. So in terms of services, let's run through these a little bit quickly to make sure we don't run over time. So again, we spoke about differentiated models of service delivery for HIV treatment, when, the where, the who, and the what. And we have to reimagine how we deliver service to persons living with HIV if we stand any chance are getting to 95,000, because what we're doing right now is just about getting us to about 90, maybe 92, 93. The most difficult part of the journey is the last bit, not the first bit. Big steps at the beginning, the small steps at the end. So this one sort of raised my eyebrows a little bit, that meeting persons where they are and starting treatment outside the healthcare facility. So in some parts of the world, community testing is the most common form of testing, whether it's payer-based or at a healthcare facility. And we know that there is a huge attrition between diagnosis and appearance at an ART treatment site. So one of the recommendations the WHO came up with was, will allow the testing site to start the treatment process. Even if it says they have to take over CD4 and viral load and labs and send it to the treatment site, link them to that treatment site, but start treatment on day one. Because once, I don't know if we have any payers with us, but we know that sometimes to get someone to the treatment site. So multi-month dispensing, this is essentially emphasizing what was stated in 2016 guidelines, that we should be thinking about 2 to 6 months appointments and 2 to 6 months ART refills. And to the integration of services. So some of these are, I think, new to the guidance, but not new to our experience. That integrating sexual and reproductive health services, including contraception, results in greater uptake of sexual and reproductive health services, including contraception. If you make it available for someone at your clinic or at your health facility, then there's less stigma, less concern. I mean, I have had patients tell me, do I need to tell the doctor when I do my pap smear that I have HIV? I don't want to know, can they find out? So it helps with respect to getting those services accepted by patients. And same thing with diabetes and hypertension, that we know non-communicable disease is on the rise. We know that persons with HIV have a significant concentration of risk factors for cardiovascular disease. And there is some evidence that management of non-communicable diseases at the same time as management of someone's HIV can result in better outcomes. In terms of re-engagement in care, so treatment programs should have practices to trace people who have disengaged from care. So we have 2 patient tracers at Mrftt who work every day trying to get patients back into care. There is a greater yield in getting patients back into care probably for them a shorter periods of time, preferably under 7 days of missed appointment. But the priority groups are suggested patients who have with advanced disease who have started treatment in the last 6 months. Those are the persons who are most likely to return to care. Persons who are pre-ART, which means if they are not suppressed and at a greater risk of progression of disease as well as transmission of virus, and persons with abnormal test results. The one concern that programs must have is you have to be alert to the possibility of inadvertent HIV disclosure to family, partners, neighbors, and the risk for stigma discrimination and even gender-based violence. And just one last thing. The last thing someone who's returning to care needs is a lecture. So we have to make sure that we are non-judgmental approach, that you are welcoming them back to care, not dragging them back to care. And again, new to the guidelines, not new to our experience, adolescents living with HIV have a myriad of psychosocial issues that must be addressed in a programmatic way at any facility that is offering service to youth and adolescents living with HIV. There is a growing body of evidence, I think it was 30-something studies, that showed that psychosocial interventions improve adherence, promote suppression with no evidence of harm. Preferably those techniques that have motivational interviewing, peer support, family-based interventions where possible, because that is sometimes partly psychosocial morass, and creative use of digital technology in engaging youth and adolescents in care. So in summary, 2020 guidelines emphasize evidence-based, patient-centered approaches to decentralize the care and support of persons with HIV. Adaptation of these guidelines to a local and regional context will require careful consideration of the dynamics of the epidemic in our own respective countries and the systemic factors that affect care delivery. And finally, and this is kind of personal for me, more research is needed to inform and strengthen these recommendations, as well as develop our own evidence-based interventions in our own territories. And that is it from me. Thank you for your attention. About 2:35, so you can probably accommodate a couple of questions if anyone has any questions they'd like to ask. I hope I wasn't talking to myself. If not, if you're not able to speak very well, what type of question in chat? If there are no questions, again, let me. Yes. Yeah.
The efavirenz 400 milligrams.
Yeah.
Is it something that is available or will become available soon?
So
because most people seem to have more problems with the 600 milligrams, which we've been stuck on for ages.
So I mean, it has been available in the region for some time. I remember some of the people came from Ghana.
Okay.
The only concern with that is given, because right now I think one of the things we're doing is trying to figure out what our baseline resistance rates are to non-nucleosides. I don't know that investing in efavirenz is going to be of benefit from a viral suppression standpoint, but it might have an adherence issue. It might have an adherence. It's going to get less symptoms. You still use with TB and Frampacin. So it's good with one, but we don't want to be stuck on efavirenz.
Is WHO concerned about weight gain with integrase inhibitors?
So not so much integrate, but with TAF. You realize that TAF is not on any of the backbones, first or second line, except in children, right? Because the consumer tenofovir diprox, that's a prox in children, as again, bone and renal, in the growing skeleton and the developing kidneys. So with TAF, we don't have to worry about that. But the concern with TAF in adults is the weight gain and the potential for cardiometabolic disease long term. So it's not yet recommended. It's not there.
And without baseline viral load, then we'd never know who are possible elite suppressors.
Exactly. So that was the argument we had. Or so we had a couple of cases.
Yeah.
Not only these suppressive, people who were issued negative, they had a false positive rapidness for whatever inflammatory condition. They would have been there was someone who was on medication for months. I think that's when the viral machine did that. And when we finally got back the viral load, we did it. I think the baseline was untested. We actually requested blood and also the fact that you realize that this person has some sort of inflammatory condition. Yeah. Test.